Hello, and thank you for joining us this evening for 10 common mistakes made when running visual fields. With us today is Molly Nettle. She's a clinical application specialist for Haag-Streit USA. She's a certified ophthalmic medical technologist and has previous clinical experience in both ophthalmology and optometry practice. She has 8 years of visual field experience and is still growing. Big welcome to you, Molly. As we go through here this evening, next slide. We need to cover some housekeeping items with the Zoom functionalities. If you could please refrain from entering any questions or comments in the chat, and please use the Q&A function. I'd greatly appreciate it. The next item is that if you view your chat, you will have, or excuse me, you'll see a link to contact Haag-Streit. So if you need something that perhaps we weren't able to capture this evening, feel free to use the contact Haag-Streit link that's in the chat. Additionally, I need to let you know that the meeting is recorded and has been pre-recorded. For further resources, please also review your chat. For the registration for the Perimetry Focus Month, we are hosting Focus Month all month this month. So please feel free to register for any of the additional programs that we are hosting. You can also find the e-learning Visual Field Digest and PDF to the Visual Field Digest in the chat function as well.
Thank you, Tanya, and hello, everyone. Today, I will be going over 10 common mistakes when we as technicians perform visual fields. First, let us go over some of the basics. Like, what is a visual field? A visual field is the area in which a person can see at a given moment relative to the direction of fixation without head or eye movement. In other words, it defines the boundaries of the area beyond which nothing can be seen. So what does a normal visual field look like? The average normal monocular visual field covers 60 degrees nasal, 90 plus degrees temporal, 60 degrees superior, and 70 degrees inferior. The method we use to test a patient's visual field is called perimetry. A perimeter will accurately quantify a patient's sensitivity to light throughout the visual field in a systemic, highly standardized manner. But why do we do this? There are many reasons why, and I've listed them here. We run visual fields to detect pathology, to evaluate disease status, follow up of pathologies to determine disease progression or stability, to determine efficacy of treatment, or visual ability testing. There are two main types of perimetry, static or kinetic. Automated static perimetry uses stimuli of varying luminance levels to determine visual sensitivity thresholds at a specific number of fixed locations. We are looking for the decibel of light the patient goes from seeing to non-seeing. This is also known as a threshold. The results at each data point are then compared to normal values for a group of people of the same age. This method can detect small changes in sensitivity thresholds with relatively high accuracy. Next, we have kinetic perimetry. Kinetic perimetry uses a moving stimulus of predetermined light intensities. These stimuli are moved from non-seeing to seeing areas. The patient responds when they see the light. These responses define the visual field location of the specific light intensity thresholds. This is done with different sizes and intensities of light. And these are the results. In static perimetry, each sensitivity threshold is displayed independently, either as a number or as a color. In kinetic perimetry, areas of equal threshold form an eye socket. Each color represents a specific size and intensity of light. You can also show local areas of depression inside an eye socket called a scotoma. Let's break down the basics of how to run a visual field. The patient will need to be in a stable position, preferably in a comfortable chair with their head resting on a forehead and/or chin rest. We must ensure to patch the opposite eye unless we are testing binocularly. We will ask the patient to focus on a central fixation target, then instruct them to respond when they see a light. That sounds simple enough, right? It can be, but also there are many other factors that need to be taken into consideration. Perimetry is a subjective test. This means we are relying solely on the patient and their responses. Your patient can start looking around. They may get distracted by someone talking, maybe a random light, or they have a headache. We've all had trigger happy patients. They really want to do well on the quote unquote test. Maybe they don't really understand what they're doing, possibly due to poor instruction or a language barrier. Or maybe they're just tired. All of this can have a negative effect on the test results. So the big question is, what can we as technicians do to ensure the visual field results are as accurate as possible? Here are 10 common mistakes made when running visual field results and how to fix them. Our first mistake that can be made, and one of the more important, is entering incorrect patient information. Now, what type of information do we need about the patient? We need to be able to identify them. So name is important. Excuse me, technical difficulties. There we go. Now, what type of information do we need? Again, name is important, first and last name. Sometimes we use ID number and birth date. We also need to know the patient's most recent distance refraction. This will help us calculate how to correct the patient for the visual field with trial lenses. Yes, identifiers are important for a lot of reasons, but to ensure the results of your field are as accurate as possible, the most important information you will be entering is the patient's birth date and their most recent refraction. But why? Let's start with the birth date. Patient's visual field results are compared to the data for an average normal person of the same age. It wouldn't be fair to compare an 85-year-old patient's results to a 20-year-old's average normal. As shown here, if the date of birth of a 58-year-old is incorrectly entered so that the patient's age is 88 in the perimeter, the results will be artificially good. If the same patient is entered in as an 18-year-old, the results will artificially be bad. Now let's talk refraction. When running visual fields on a patient, it is crucial for the patient to be able to see the fixation target as clearly as possible. If the patient isn't corrected properly, it can cause their vision to be blurry and they will miss some stimulus. Essentially, this will poorly affect their results. So we just put in the patient's distance refraction, sphere and cylinder power into the trial lens holder, right? It's not quite that easy. Typically, bowl perimeters are set up to present stimuli at a distance of 30 centimeters from the patient's eye. This is a typical reading distance for most patients, and we all know as technicians, as patients get older, they lose accommodation and the ability to read up close. The older they get, to the higher power reading glasses they need. Similar rules apply for visual fields. Younger patients are able to accommodate at that 30 centimeters, but as patients get older, they're going to need a little extra help. So how do we calculate the trial lens needed for each patient? Well, first, we're going to need to know the patient's most up-to-date distance refraction. Then we need to calculate the add for age correction for that individual patient. This is based on their birth date. That is calculated based off of this formula and this table. We will then add the add for age calculated lens to the patient's distance correction. Oh, by the way, we're going to use spherical equivalent up to 1 diopter of astigmatism. So does that sound complicated enough? Because it is. Thankfully, the majority of automated perimeters make it a lot easier on us. All you have to do is input the patient's most recent distance refraction, choose which eye we want to run a field on, and the instrument does the calculation for you. Does that sound a bit better? Moral of this story is we need to ensure the patient is seeing as clearly as possible when performing a visual field. And what is the easiest way to do that? You can ask them, can you see that green cross clearly? If they say no, adjust the trial lenses one way or another until they do. You will especially want to keep an eye out for this with your patients that have had cataract surgery or are dilated. Those patients typically lose their ability to accommodate and may need a little extra help. For more information on how your Octopus 900 perimeter will calculate the proper trial lens, please refer to the Visual Field Digest found on the Haag-Streit website. Now, if you're using an Octopus 600 perimeter, Haag-Streit has a built-in plus 325 lens for each eye to compensate for the viewing distance when patients look at the monitor. Therefore, the stimulus are projected at infinity. As with the Octopus 900, the instrument will automatically calculate the trial lens needed for each eye. But you will notice that no add for age correction is needed. Everybody ready to move on from this optics lesson? Because I am. Let's move on to something a little easier. How to put a patch on. The majority of visual fields we run are monocular visual fields, meaning we're testing one eye at a time. For this reason, we need to patch the opposite eye so it does not help its buddy with its test. However, if we do not patch the opposite eye correctly, it can actually be a hindrance. If you're using a patch with a string, it is important to ensure the string is not interfering with the field of the testing eye. If it is covering the testing eye's lid, like in the image with the red box, it can falsely simulate a droopy lid and interfere with the field results. We also need to ensure the patient is able to blink freely. If this is not the case, it can be very distracting for the patient. It is important for the patch to be translucent to allow some light to come through. Why is this important? If a dark patch is used, it can cause an intermittent darkening of the visual field. This blank out is eliminated by using a translucent occluder. Our next mistake that could be made is choosing the incorrect fixation target, not only for the visual field being performed, but for the patient. The goal when choosing a fixation target is to promote steady fixation throughout the entire visual field. Octopus perimeters offer you 3 different options for fixation targets: an open cross, a central point, and a 5-degree ring. They all have a time and place. The default or standard fixation target is an open green cross. For reasons we will talk about soon, it is a lot easier for a patient to look inside the green cross than it is to look at a central point. It also does not cover the foveal stimulus location, excuse me. The central point target can be used as an alternative method for some patients with poor understanding. It is the most recommended target when kinetically plotting a blind spot or scotoma. However, using a central point fixation target can unintentionally induce the Troxler effect. In 1804, a Swiss physician and philosopher made the discovery that rigidly fixating one's gaze on some element inside the visual field can cause surrounding images to slowly seem to fade or disappear. By forcing your eyes not to deviate from a single central point, essentially giving your retinal cells no new information to process, you're telling your brain to ignore anything other than that point, that nothing around it is important. Your brain then fills in the surrounding information by blurring it together, deeming it too boring to process. If you were to stare at the red point in the center of this ring, at about 20 seconds, the green ring would start to fade. Now, the quickest threshold visual field I have seen was about 2.5 minutes. Imagine focusing on the red dot that whole time. Using an open cross fixation target helps to eliminate this fading for the entirety of the field. For patients with severe vision loss, a 5-degree ring is the preferred fixation target. These patients may have advanced glaucoma or macular degeneration and are able to see the green cross. The use of the larger target is recommended to provide an estimate of the location of the fixation target. The next mistake I want to talk about is patient alignment. If the patient is uncomfortable or their eye is not lined up correctly, this can have a great impact on how the field goes and essentially the results. Patient alignment is a two-step process. We first need to ensure that the patient's back and head are aligned correctly with the instrument. We then need to line the patient's eye up to the fixation target and video monitor. For any perimeter, it is important that the patient is in a comfortable position that can be easily maintained throughout the field. If you're using a bowl perimeter, such as the Octopus 900, the patient should sit as close to the device as possible with their neck and back in a straight upright position. The height of the table should be set so that the patient can maintain this position while comfortably resting their chin in the chin rest with their head touching the forehead rest. Make sure the table height is not too high that the patient has to reach or too low that the patient has to slouch. Both of these positions would be hard to maintain for the duration of the field. Now the 600 does not come with a chin rest, so lining up a patient is a bit different. The patient should be positioned leaning forward with a downward facing gaze. This is best achieved by seating the patient 8 inches away from the instrument with the height of the forehead rest level with the patient's eyes. The patient will then lean forward, bringing their chin in slightly, so the forehead rest ends up a couple inches above their eyebrows. Because the patient's head is fully leaning on the headrest, it will provide a stable position for the entirety of the field. When we're talking about eye position, most visual field instruments make it pretty easy. Typically, the goal is to adjust the patient so the cross intersects the center of the patient's pupil. This can easily be done with the up, down, left, and right arrows that adjust the forehead and chin rest. When it comes to the Octopus 600, you want to ensure the patient's eye is as close to the center of the box as possible. The box will then turn green with proper eye placement. Because there's no chin rest, you will have to ask the patient to move their head slightly up, down, left, or right if necessary. You can also bring the patient's forehead closer or push them farther away for better illumination. Proper eye placement is important for the patient to see properly the fixation target along with stimulus throughout the visual field. With your Octopus perimeters, it is also important for fixation control. Fixation control feature tracks the patient's pupil to ensure the patient is looking straight ahead during the field. If the patient looks around, closes their eye, or is not properly settled on the forehead rest, the fixation control will pause the field until the patient resumes proper fixation. This ensures 100% reliability when it comes to fixation with your Octopus perimeter. Our next step is proper trial lens placement. When testing a visual field within 30 degrees, the patient should have proper correction placed in front of their testing eye. If you're using the Octopus 600, this is as simple as choosing the appropriate large blue-rimmed spherical trial lens provided with your instrument, popping that trial lens into the magnetic holder, then lining up the patient. There's a little more to it when it comes to using the smaller trial lenses typically used with a bowl perimeter. After placing either 1 or 2 trial lenses into the trial lens holder of your bowl perimeter, it is imperative to place that trial lens as close to the patient's eye as possible without touching the patient's eyelashes. If the trial lens is left too far away from the patient or off center, it can interfere with the patient's ability to see presented stimuli. This can potentially cause the dreaded rim artifact. So what is this rim artifact? Let me tell you. If the trial lens is not placed as close as possible to the patient's eye, the rim of the lens can block the patient's view. This can in turn affect the patient's results, causing an absolute defect around the edges. The rim artifact can be avoided by paying close attention when lining up the trial lens with each patient. Number 6 on the list of common mistakes is not taking into consideration your patient's physical anatomy or behavior. Our patient's facial structure is a very important factor when setting up the visual field. If our patient has a large nose or long eyelashes, this can alter their field of view and give false visual field results. If this is the case, it is best to turn or tilt the patient's head just slightly. Two of the most common anatomy-based influences are droopy eyelids and small pupils. Both of these can also interfere with the patient's field of view. If your patient suffers from droopy lids, it may be necessary to lightly tape up that lid so it does not interfere with the field. Be sure to not tape it up too tightly, as we still need to allow the patient to blink. When it comes to pupils, the rule of thumb is that the pupil must have a diameter of at least 3 millimeters to not interfere with the field of view. If the pupil is smaller than 3 millimeters, it can decrease the amount of incident light on the retina, and your field can have a uniform depression. It is recommended to dilate a pupil of 3 millimeters or less prior to running a visual field on that patient, but you always need to consult with your physician prior to dilating. Something else to watch out for is if your patient has dry eyes. For anybody that has experienced dryness, we know that it can blur our vision and change upon each blink. This is why it is important for us as technicians to encourage patients to blink throughout the visual field. Thankfully, your octopus perimeter knows each time a patient blinks and will represent that same stimulus later on in the visual field, so no data is lost. My last point when it comes to physicality of our patient is the fatigue effect. Taking a visual field requires the patient to be alert and attentive. If the patient is tired the day of testing, their attention on the test at hand may decrease. This can in turn cause inconsistent responses and false negatives, typically showing results worse than patient's true visual field. It is the technician's responsibility to notice if the patient is tired or distracted and keep their focus on the task at hand. I've already done an overview on the differences between static and kinetic perimetry, but now it's time to dive a little deeper. There is a time and place for which each is appropriate. In some circumstances, you may be able to use either, but one is usually better. Let's look at each method individually first. Static perimetry is considered the gold standard. It has a high precision sensitivity threshold and is fully automated, which makes it easier for the technicians to focus on the patient. Static testing is best at detecting small changes in sensitivity thresholds, especially in the central vision. Kinetic sensitivity has a higher spatial resolution and is more efficient when testing in the periphery. Because it is not fully automated, it is easier for the technicians to cater to visual needs of the patient. It is best used to detect peripheral changes, including small scotomas. It is also very useful at testing the remaining vision in advanced stage diseases. So when is it best to use kinetic testing and when is it best to use static? That's a great question. Although glaucoma is a peripheral vision disease, it is the most common disease tested with static perimetry. Why? Early glaucomatous visual field defects are subtle and easily missed, even with the technology perimeters have today. Glaucomatous visual field loss is not evident until at least 30% of the retinal ganglion cell axons that make up the optic nerve have been lost. Visual field loss in glaucoma can be quite slow, which is why we must use the most sensitive method possible that allows progression analysis. The same theory applies for macular disease. Alternatively, when we are testing outside central 30 degrees, kinetic is the most efficient test method. It is more patient-friendly and has a higher spatial resolution than static. Kinetic testing is the best option when we test for neurological disease, peripheral retinal disease, ptosis, driver's license testing, as well as when we're running a field on a child. The image here shows the detection of a ring scotoma in a patient with retinitis pigmentosa. The kinetic testing provides a much higher spatial resolution with even the smallest details compared to static fields. It was also done in nearly half the time. Another great example of when to utilize kinetic testing over static is when running a visual field on patients that potentially need lid surgery. Let's start with static. This image shows the results of an untaped ptosis field with either a seen or not seen static strategy. The plus signs are the stimulus the patient saw, and the black boxes are the ones the patient did not see. And as you see here, apparently this patient has a hole in their lid. Or this is a really good example as to how difficult it is to maintain accuracy with static light outside 30 degrees. This one field took 4 minutes and 11 seconds. If you're familiar with ptosis testing, you know we have to run this exact field again with the patient's lid taped up. This is done to assess the quantity of vision the patient will gain back after lid surgery. Now, if you do the math, that's an over 8-minute field and over 4 minutes of the patient's lid taped up so they can't blink. Then we have to do the other eye. Alternatively, we could run this field with kinetic perimetry. We use a moving light starting above the patient's view, moving down until the patient sees it and responds. We do this 13 times untaped and 13 times taped. This entire field took 3 minutes and 38 seconds taped and untaped. That is faster than doing untaped with static. We are also able to show the results on one piece of paper instead of two. And the Octopus offers a tool that quantifies the area of vision the patient will be gaining back. Not only is kinetic testing faster outside 30 degrees, it's also more patient-friendly. If the method of testing is the how, we're going to call number 8 the where. Next on the list is testing the correct location for a specific disease. The goal with picking the correct test pattern is to maximize the parametric information you obtain while minimizing the test duration. We do this by choosing the pattern with high density of test locations in the area of high interest, low density of test locations in areas of low interest. As the majority of visual fields do, let us look at glaucoma. We have previously discussed glaucoma defects occur most commonly along the nerve fiber bundles. So how about we test there? The Octopus G pattern does exactly that. It consists of 59 locations within central 30 degrees, distributed in a pattern that facilitates detection of visual loss associated with not only glaucoma, but also neuro and macular disease. The test locations are distributed along the retinal nerve fiber bundles. With 17 points within the macula, including 5 in the fovea, the GE program also focuses on the most important area of patient's vision, allowing for additional detection of macular disease. The test locations specifically straddle the horizontal and vertical meridians to accommodate for neurological disease. The G pattern serves as a multifunctional test and offers an excellent trade-off between test duration and accuracy. If we have a patient with macular disease, such as macular degeneration, or maybe we are testing for plaquenil toxicity, we will need to focus in a little bit more, within central 10 degrees to be specific. For these cases, we have the M pattern. It has 81 test locations, with 45 of them focusing on the foveal area of central 4 degrees. We are testing a high density of locations in the most essential area of vision. Now let's say our patient has advanced glaucoma and they have severely constricted field. At this stage, the patient's only remaining vision is in the macular area. If we were to run the G pattern, 65% of the field would be known area of non-seeing. That is not a very efficient way to test. So instead, we run the M pattern. This pattern will maximize the amount of parametric information we receive within a similar testing time. Now that we've talked about patterns of testing, the natural next step is talking strategy of testing. How do we decide on the correct strategy? The goal with the strategy is similar to a pattern. Minimize test duration while maximizing clinically relevant information. There are 2 different types of strategies. Qualitative will simply determine whether a stimulus is seen or not seen. In other words, whether the patient has normal or abnormal vision in that specific location. Quantitative will give us an estimate of the local sensitivity threshold and therefore provide us with progression analysis over time. In theory, it would be great if we could use a quantitative strategy with every field, but even the most accurate threshold tests can lead to inaccurate results if the patient is unable to perform reliably for the duration. So time is definitely a factor. When can we use a qualitative strategy then? This type of field is best if running a static field for driving test, legal blindness, ptosis, as we talked about before, and also blind spot testing. Keep in mind, each of these types of fields can also be run with a kinetic testing. I mentioned the number one reason for running a visual field is glaucoma. Glaucoma fields are run with a quantitative strategy. As a refresher, the goal here is to determine the decibel of light the patient goes from seeing to non-seeing. We then use these numbers to both compare to a database of age-matched normal eyes and to previous threshold visual fields the patient has done. By doing this, we can determine if the patient has a defect corresponding with a specific disease and, over time, if it is progressing. There are multiple quantitative threshold strategies. I will outline the three main strategies in octopus perimetry here. Starting with normal strategy, it takes 10 to 12 minutes per eye. Now, that seems like a really long time, and it is, but it will give you a high level of detail and accuracy of plus or minus 1 decibel at each location. It's also important to note the field starts with a dim light. Typically, this strategy is only used in research. Moving on to dynamic strategy. These fields will take 4 to 8 minutes per eye, with a high level of accuracy with early disease at plus or minus 1 decibel and slightly less accuracy at plus or minus 5 in areas of advanced defects. It also starts with a dim light. Top strategy, however, can run a threshold field in under 3 minutes per eye. Now that's pretty fast, but of course there has to be a trade-off. It can smooth the edges of scotomas and is less sensitive to small, localized defects compared to dynamic and normal. It does, however, start with a bright light. When you choose a threshold strategy, there is a trade-off between test duration and accuracy. In this example, all strategies allowed the identification of a double arcuate defect. The field done in top strategy shows the defect with a shallower and smoother edges, but was also done in nearly half the speed. Many physicians using Octopus have determined the increased patient understanding with the patient seeing an initial light, along with the decreased time avoiding the fatigue effect, are advantages they are looking for in a quantitative threshold strategy. Octopus and iSuite offer you all three options to allow you to make the decision that's best for each patient. We made it, everyone. We're on number 10 of common mistakes when running visual fields. And in my opinion, this is the most important. You can input the correct patient information, put in the correct trial lens, choose the right visual field pattern and strategy, and line the patient up correctly. But if the patient has no idea what they are doing, the results will essentially be unreliable. It is important for the technician to explain three important messages: the aim of the test, what the patient should expect to see, and what the patient is expected to do. These three things are fundamental for the patient to understand what they are about to do. Better understanding leads to more reliable results. Let's break down each of these statements a little bit more. What is the aim of the test? We're testing your peripheral vision. What are they expected to see? While looking straight ahead at the open green cross, you will see white flashes in your periphery. Some lights may be dim, some bright, some big, some small, and some you won't see at all, and that's okay. What are they expected to do? As soon as you think you see a white flash, click the patient response button. Don't look at the flash, only look inside the green cross. See how I mentioned that one twice? Blink regularly. If you think you missed a light while you blink, that's okay. The instrument knows that and will represent that light later on. By explaining each of these points, you are easing the patient's mind. Some patients come into the room thinking the field is a pass or fail test. Those are going to be your trigger happy patients, high false positives, and an unreliable field. We need to reassure our patients that this is not a test and ensure they understand what to do. I always think of visual field techs as cheerleaders. We're there to cheer our patients on throughout the entire field to ensure their confidence is high to get the best results. And there are 10 common mistakes when running visual fields, and I hope you learned a few tricks on how to fix them. Thanks, everyone. We're going to open up to questions now.
Thank you all. Thank you, Molly. Opening it up for questions now. Again, if you have any questions, please put those in the Q&A and not in the chat. We do have a few questions here already, Molly. The first question is, do the lenses provided with the Octopus 600 correct for astigmatism? And I think we may have lost Molly.
I'm back. Sorry about that. Sorry, I had a power outage here. It's raining.
No problem. So Molly, the first question was, do the trial lenses provided with the Octopus 600 correct for astigmatism?
They do not. So the trial lenses that come with your 600 are those blue spherical equivalent trial lenses that just pop directly into the instrument. Like I said, they're 1 diopter spherical increments. Your Octopus is going to recommend using those up to 1 diopter of astigmatism. After that, it's going to recommend an alternative method. So it does say patient's glasses, but I recommend using contact lenses or one of those half moon trial frames before that. You can use patient's glasses. That's how it was built. But you just want to make sure that they're made correctly, that the bifocal is not going to be in the way, and that the frames aren't going to be in the way of the patient's vision.
Great. The next question is, when we put the corrective lens, are we supposed to include the add power on top of the distance RX for presbyopic patients?
So it depends on the patient, it depends on the instrument. So with your 600, you do not have to. The instrument already corrects for age, so you only need the distance prescription. For the Octopus 900, you do need to correct for that goal distance, so that near add. So depending on the patient's age, once you input it into the Octopus is going to recommend a trial lens with the add for age already in it. So whatever the Octopus recommends for you is what you should use. Don't add anything on top of it.
Excellent. The next question here is, can an Octopus 600 run a ptosis or driver's license screening?
Great question. I get this a lot, and the answer is no. The Octopus 600 is a 30-degree field. It is a static perimeter only, and as we talked about, kinetic perimetry works best for ptosis and driver's license, and you also need a full field perimeter. So the Octopus 900 would be the best option for that.
The next question here, and just as a reminder, if everybody wants to put any questions that you have in the Q&A, we'll be happy to answer any questions you have. So just put those in the Q&A, please. Next question here is, what if an office doesn't want to use a reusable patch? Is there an alternative?
That's the world we live in now, isn't it? Your perimeters, when it's purchased, you get a disposable patch that has a string that wraps around the patient's head. Now, in the world we're in now, a lot of people are moving towards disposable patches, which actually that's what I used when I was working in clinic. Just those disposable Band-Aid optic-glued patches work really well, and some patients prefer them. So I believe you can get them at any drugstore, order them online.
Thank you. The next question here is, when we put the corrective lens with the Octopus 300, are we supposed to include the add power on top of the distance RX for presbyopic patients?
I'm not positive about the Octopus 300. I'm more familiar with the 600 and 900, but if you want to write into the website or contact us directly, we can help answer that question for you.
Great. Thank you, Molly. I'm not seeing any more questions here at the moment. I'll give it a few more minutes here so that if anybody has any questions, feel free to put those in the chat. And I'll just continue to wait for a few moments to allow any of those questions to come through still. We do have another comment question asking if the webinar will be available as a recording to share with their technicians, and the answer to that is yes. It should be posted on our YouTube channel and will also be sent out after the recording is completed. Probably tomorrow you should receive a thank you for attending, and you'll receive the link to rewatch the webinar as well. So thank you for that feedback. It doesn't appear that there are any other questions at this time. We're finishing up a bit early here, but I'm sure you all are ready to get on with your night, and we are excited that Molly was here with us tonight. Thank you so much, Molly, to help us along with these really important questions about visual field testing. I thank you all for your time, and I hope you all have a wonderful evening.
Thank you, Tanya, and thank you, everyone. Have a good night.